We're ready. So now it should be speaker, microphone. Okay. We are already recording this. Very good. So welcome to this special interest group on myopia management. I have with me Dr. Shifra Harrington and Dr. Catherine Saunders, both from Ireland. Yes. My name is Jose Manuel González Mejome, and I will be moderating this session. But this session will be mostly conducted by Shifra, presenting us the navigator built by the World Council of Optometry on myopia management. So we will ask your interaction during the session through this QR code. So you can scan, can go to the next one. Okay. You can scan this QR code with your phones, and there will be 4 questions with 4 options. So you can choose whatever it's more appropriate. Probably sometimes you would like to answer more than one, but you have to choose one. It's a forced choice question. And then we will go through the presentation to try to clarify some aspects related with the clinical management of myopia control. At any point, you might have any question, please raise your hand and pose the question to the audience. So Shifra, the floor is yours. We are ready with our phones to participate.
Very good. Thank you, Jose. My name is Shifra Harrington. I'm coming here today. We're in Helsinki, and I'm based in Dublin in the National Optometry Centre in Technological University Dublin, and also I'm based in the Centre for Eye Research in Ireland. But really what I want to talk to you today about is the new World Council of Optometry Myopia Management Navigator. And that is designed just to help people look at evidence-based clinical decision-making regarding myopia at a very high level or at a more detailed level, depending on what level you're at or what your scope of practice is. And we'll look at it in detail later on, but let's just talk about initially challenges and opportunities for myopia management. And today we'll break down this talk into 4 sections. The first question will address when do we start treating myopia, and Catherine is going to talk about that with us today. She has vast experience in this area, and if it wasn't for Catherine, I mightn't even have got into this area. So I'm delighted that she's here, and Jose has fantastic background in myopia as well. But I suppose now we're thinking about when do we actually start? Is there a specific moment in time? And then how do we decide how best to treat kiddos with myopia? How do we monitor if the treatment is working or not? And when do we stop? When does this relationship end? In general, I find in practice it's one that goes on for years, for decades actually, because you're working with children from an early stage right through adolescence and into early adulthood. But you can see another QR code here, and this will link you directly into the WCO Myopia Management Navigator if you want to take a look at that. So everyone knows at this stage the prevalence of myopia is increasing, and we also know that while this may not be problematic because we can correct it with glasses or contact lenses, but the prevalence of high myopia is also increasing. And this is due to myopia, which is a chronic condition. And there are things we can do to mitigate against myopia. In other words, prevent children from becoming myopic, but also to limit the extent of myopia they might end up with. And there are very many reasons for doing this. We know from Ian Flitcroft's paper from 2012 that there is no safe level of myopia because your odds for pathology increase significantly. And you can see that on the slide here. Like if you look at myopic maculopathy, once you hit -8 diopters of myopia, we can see you're 127 times more likely to suffer with this. And now in practice, we know that -8 really isn't that high anymore. I'm not sure how you find this, but I find in practice that we're often hitting the double digits, and this is an issue. So what can we do about it? Every diopter matters. We cannot prevent many children from becoming myopic, but we can reduce the amount of myopia. And we'll think about what our treatment goals are. So we want to reduce the amount of myopia because it'll be easier to correct. Therefore, you might be a better candidate for refractive surgery. And I think that's very important because I find the trickiest parents, I don't know what you call it, but I find parents who are very tricky to deal with are parents who've had refractive surgery because they think their child can be, corrected in time to come. Whereas if you have -10, -11, -12, -13, level of myopia, that's not a straightforward refractive surgery at all. Shorter axial length is where we need to go. And maybe in the future, we may be able to think about preventing myopia onset. Obviously not, syndromic myopia, but myopia associated with the way we live our lives today. So that's just one way of thinking about it. There are non-modifiable factors. Okay, if you're one parent is short-sighted, you're 3 times more likely to be short-sighted. And if both parents are short-sighted, this brings it up to 7 times greater risk. And also ethnicity. We know that children who are Southeast Asian are more likely to be short-sighted. However, there is research that shows that, when children from Southeast Asia are based in Australia, they're less likely to be short-sighted than when based in Singapore. So it's an open question. Things that we do know are important and that we can modify are the amount of time children engage in their work. So we know that working at less than 30 centimeters, more than 30 minutes, increases your odds of becoming short-sighted. And we do know from work that was carried out in Australia that children work between 20 and 25 centimeters. And this is something, Catherine, you had identified years ago with Maggie Woodhouse when you were developing the UC Cube. It's calibrated for 20 centimeters and 25 centimeters. So we know that children spend a long time looking at very short distances. And in fact, when they're on their smartphones, have you ever seen a myopic child on the train on their smartphone? That's 10 centimeters in front of their face. So when you think of the accommodative load associated with that. So these are things that we need to educate parents about and children themselves directly. Also outdoor time. And, in 2008, Catherine Rose had that seminal paper where she identified that outdoor time and daylight could be protective against myopia. And I've pulled a slide here from Gareth Lingham's paper in 2019. And I really like it because you can see here in the image that he's identified beautifully and visually the various factors associated with myopia. What's the difference between being indoors and out of doors? Well, first it's brighter outside. It's brighter. And therefore, the higher the degree of illumination, the more protective. Again, when you are outside, you have more myopic pupils. That's going to reduce the amount of peripheral defocus. Also, I think a very interesting area that's attracting a lot of attention now, and also in Arvo last week, is looking at higher spatial frequency in outdoors compared to indoors. As you can see here, the detail we have outdoors in our peripheral vision that we don't have indoors. And I know that I think Ian Flickcroft was involved in a study based in China where they altered the classroom walls so that they're more similar to being outdoors. And the results presented this week at Arvo would suggest that it did slow the degree of myopia, the rate of myopia progression. Chromatic composition, I think this is big. Outdoors, we have bright, full spectrum daylight. And indoors now we have LED lights, which are a mixed synthetic lighting. You're talking about a mixture of blue and red and green, nearly 50% blue, but it's a mixture of blue and red and green. Whereas before, incandescent light was like, I suppose, this contained fire, if you think of it like that. And because of that, you still had broad spectrum light, but we don't have that. And I think this is important because when you look here, longitudinal chromatic aberration would appear to give some idea as to how the eye should grow. So basically, we know that when we have broad spectrum light, longitudinal chromatic aberration helps the stop-go system when it comes to eye growth. If you have a red emphasis, you can see, or blue emphasis, the system feels that the eye is too short, therefore keep growing. And then the contrast, if you have you have red image contrast, you have the opposite. And we do know artificial lighting is heavier on blue content. So the animal studies, like Sabal Canal found in the States, the animal studies have shown that tree shrews who were exposed to narrow spectrum blue light, they tend to drift through the equivalent of about 1.37 diopters of myopia, like we're seeing in children today. So I think what we'll do now is, I hope, can move on to the first. Have I done something? Move on to, what else is important? The age of onset is a primary indicator or determinant of progression. The younger you are when you become short-sighted, the more short-sighted or myopic you become. And also the degree of hyperopic reserve. I've skipped over that slide. So children who are pre-myopic, in other words, who have less hyperopia than you would expect at a period of time, you can see here on this slide, we know that these children are likely to become myopic, and it's a good time to jump in and talk about environmental risk factors. So now we'll move into the first question. So you can see where you're based here. So when should we start treatment? What do you think? Jose and Catherine, what are your feelings on this?
As soon as possible. As soon as it makes sense.
As soon as, and how do we
This is my safe answer.
I think you need to make sure they're going to wear, if it's a
We
wear.
can go to the next one for voting. Okay.
Oh, yes, so now you can start to vote. And I think the thing about this is I came up with these response options based on listening to different people who work with me about when they identify a good time. There's no right and wrong answer here, but I think it would be very useful to learn how we approach this and do we approach things in different ways and how that aligns. Or we can leave it open. But yes.
We have already 12 voted, so you can go to the next to see how is the
what
figures.
Does it look like? And while we're doing that.
Okay.
Oh, look at this.
That's what you mean by treatment, Shifa. I suppose
It
that's my
does.
question.
It does, doesn't it? In fact, I don't even like the treatment now, okay?
So if you're thinking about an intervention that involves spending more time outdoors, balancing the visual diet between near vision tasks and time spent outdoors, and being sort of healthier about your approach to that, a bit like you're healthy about your diet, then you would absolutely start in those pre-myopic years, and you'd be encouraging and targeting parents and children who are likely to become myopic and saying, you know, these are the ways we can push back that myopia onset, because we're going to essentially, the biggest wins are likely to be by pushing back myopia onset rather than starting interventions or treatments once myopia has onset. Yeah. So I sort of agree with C if treatment means mitigating advice.
Yes. Yeah, I would agree with that. In fact, I'm inclined to think what I do in practice is I use the same advice really all of the children come in. You know, so that if they're hyperopic or if they're myopic or whatever, it's just that it's good for everybody, you know, the time outdoors or whatever. But the biggest problem is getting them in, isn't it? Because they're passing screening in school and you just don't see them.
Well, this makes me realize how important is this new term that the IMI proposed 4 or 5 years ago, pre-myopia. So before that was no myopia or myopia.
Yeah.
Now it might be something between being low hyperope, emmetrope, and before getting into myopia. So that's what we called earlier low hyperopia, emmetropia. Maybe 20 years ago, we said to the parents, that is a perfect situation. Your kid has a perfect vision.
Yeah.
Today is not a good prelude. You say.
And I think the interesting one here is B, because I actually think from what I see in practice, that's what usually happens. So that what the first step is, and most optometrists will prescribe the first myopic prescription, and then they will see how much they progress over the course of a year, so that they can say, look, there is this degree of progression. Therefore, so in other words, I think it's a very honest response, because from what I see, oh, lovely, yes, good question.
Just about the see. So
Yeah.
what you make if the child is older than 8 or 9 years old and you don't expect any hyperopic vision? So if the child is 12 years old, we get myopic, so there is no hyperopic vision anymore.
So what happens then? So once they start to become myopic, is that right? Or no, they're 12 years old.
Yeah. But basically, the problem is this answer is because this is just below 8 years old.
Yeah.
Yeah, cannot cover all the clinical situations, of course.
Yes, of
So you mean
course.
someone that is already myopic at the 12 or 11 years of age?
What do you do?
Or that is emmetropic?
Because that
So that's when you see
slightly
them.
hyperopic, you don't see this.
That's it. You have to find them. So maybe we need to look for pre-myopia. Do you know, is that the next step though? Is it? Maybe yeah, exactly. That's what we call screening, but maybe we need to modify our screening if we're going to take it seriously. I don't know. And maybe you can't cycle them. So maybe it's
Do we think the gap between B and C might be closed if you change that from dot progression to a millimeter progression in axial length in an ideal world where everyone has a myometer?
I know that should be lovely. Wouldn't it?
If you if that was the case, and there was a progression in axial length, you could demonstrate to patients and their parents with a centile chart,
Yeah.
and be able to make that demonstration earlier, and you wouldn't have to wait till they're actually not necessarily.
Yeah, having the biometry is wonderful, but we do also have algorithms now whereby if you have your spherical equivalent and you have your corneal radius, you're in a good position to work out what the axial length would be. You know,
I think you do have to be cautious because there is a lot of noise in those
There is.
calculations. So you
There
could
is.
use that to decide whether someone had a large, medium, or small eye for age.
Yes.
But it would be hard to really
I
pinpoint it.
know.
This is an interesting point. All of us agree that it's great and I would say almost indispensable to have a biometric, but we know how real world is.
That's it.
Not every eye care practitioner has a biometric.
Yeah.
Does it prevent from do any on myopia control? Maybe we will end up at a certain point to say yes. If you don't have a optical low coherence biometer or equivalent, you should not even think about doing myopia management. I think we can do much even before having that machines in every eye care practitioner, primary eye care practitioner, I will say.
Yeah.
But as we evolve, probably we will end up at the point that no way without a biometric.
Want to get cheaper.
Until there, we are, of course, we cannot do a bad work just because we don't have the right tools. But I think we can do a good work
Yeah.
with these other strategies, assuming that there is noise, that there is not a perfect correlation there in that field.
And also we've got the environmental advice as well, and visual diet and all of that type of thing as well.
Yeah, because I think that's going to be, so
Yeah.
if we have very low and you have a flat cornea,
Yeah.
and
Yeah. You see, this is the
this
point.
happens a lot, so
Yeah.
you can
Yeah, so-
already, like with such, it's a steep line, you have a short line, so you don't need to treat it.
Yeah, so there are tools out there for practitioners that
Yeah.
can do that kind of risk stratification for pre-myopic children if you know the age, the refractive error, axial length, family history, or K readings if you don't have axial biometry, and that will give you a communication tool.
Okay.
to identify.
So maybe we will better to go ahead
Go ahead.
because there is a long way in this navigation.
Hang on now.
Okay.
And okay, so we're looking at this slide here, and that's kind of summarizing a lot of that based on, you know, this new definition, as you were saying about pre-myopia. But again, as Catherine was saying, you're combining that with a baseline of the refraction, the age, and other risk factors such as, you know, parental history, and then looking at the visual diet. I think also what I find very interesting is that there's been a lot of talk about, well, daylight and environment, all that can help delay the onset. But once they're short-sighted, it doesn't matter anymore. And then everyone seems to kind of give up, well, I'm always short-sighted now, I don't need to go outside. I think it's still important to supplement whatever they're doing by encouraging that 2 hours outdoors per day. Okay, so when to start? Ages 6 to 12 years of age, we know they progress very, very quickly, and we need to get in there with, again, visual hygiene. Recommend treatment for all children at half a diopter or more. Important to fully correct. You know, sometimes, and I do work with people who think, well, they're going to be short-sighted all their life. They only have half a diopter of myopia. Maybe we'll just leave them for a year or two until they're over a diopter. I mean, that still happens. And we know from the paper by Nicola Loken and Jim Wilson that that's not a good idea. You need to fully correct myopia.
So
Oh, yes.
is all children correlated to 6 to 12-year-old, all children, or is those like 15-year-old?
Oh, I don't follow you. When to start? So in other words, in other words, any child who becomes short-sighted should be
So
corrected.
if a child gets 16 years old, 0.5 the short sighted should be treated.
Yeah, so that's would have to be an interesting study, wouldn't it?
I
Yeah,
think the risk of them progressing
It's
to
still
anything higher than that is very low. So if I had a 15-year-old coming into my clinic who was minus 50, I would not be recommending. But I might tell them about myopia control options always and give them the information. But you need to balance that with cost and with
there's a
value.
lot.
to
Maybe the
benefits.
thing is the difference in the follow-up we should adapt to each patient.
exactly.
So we should follow very close an 8-year-old progressing 0.5, but probably a little bit loose or not so tight follow up on these 15 with
And it
this
might
kind of
depend what
profile.
they were doing. If they were continuing full-time education and doing intensive study for the next 5 to 10 years, potentially there are a significant portion of myopes progress through young adulthood. So that would be another thing I would put into the equation whilst talking to parents and talking to the child themselves as well.
And then they come back to me when you're 17 looking for your eye test for your driving license. And then at that stage, you then need the boost at that stage for distance vision. So let's just see. We will move on. Yeah.
Just one side, right?
Oh yeah, go back.
Sorry.
Yeah.
So
So-
70.
Oh yeah, we're percentile charts. So you're looking at the percentile charts, and actually,
Which one? The Asian or the European?
Which
Because
depends.
75% in Asia is different one than in Europe.
it would be. I think it should be
So
important.
50
It would depend on the child and the chair, I would think. So it should be good to look at data that was relevant to the community that you're dealing with.
Yeah.
And let's see, what is myopia? What are we worried about? We're worried about axial elongation. I mean, that's what we're worried about. At the end of the day, there's a colleague of mine, Dr. Michael Moore, and he was saying, maybe we need to redefine all of this. Maybe we're not worried about some myopes. We're just worried about other myopes. They say, I have a very long axial length, but I'm not short-sighted. And whereas you have some people that, again, with their very steep corneas or whatever, that could be quite myopic, and that mightn't be an issue. So I think it's nice to think about that as well. That axial length is something that, and of course I'm spoiled. I have lots of biometers.
No, my question is just, do we need the percentile numbers? Because in European, it's 50 percentile is already myopic, or it's getting myopic. In China, it's 75 percentile. So maybe you should.
Sorry, yeah, I get you now.
It's the imageologic curve, then.
Yes, because the majority of the population are short-sighted, so that means,
Percentile.
so it's not going to be relevant. Yeah, no, I hear you now. Sorry, I missed that initially, your point there initially. Thank you for that. Okay, so this is just looking at the navigator itself so that you can see how you can use it. You can look at it at a top level. It comes under the 3 M's of mitigation, measurement, and management, so that you can remind yourself or refresh your knowledge on the different types of treatments that are available, on what measurements, how you interpret them. And there's also a lot of scenarios as well, which I kind of find useful when it comes to, working with children and deciding on what will work for them. You can look at the different scenarios and think, yeah, that'll work there. And, as children get older, their lifestyle changes, the visual task analysis changes. So therefore, we need to adapt how we treat them depending on the life that we lead. Okay, so we're going to get into this now. Question 2, how to treat. What do you think? Orthokeratology, single vision spectacles, review in 12 months, multifocal contact lenses, lifestyle changes. Let's go. That's one.
Now we can vote.
So we can only choose one.
I know.
We can only choose one.
Yeah, no, but that which makes sense.
So we choose your top ranked one.
You're killing. See, there we go. So there we go. So what are the for the first treatment? People are changing their mind. Very good.
Well, they have the right to do it. This is a psychological experiment.
Look at this.
How
There's no
we
orthocare.
interfere with each other.
Would you fit orthocare as the first correction?
No, I think but I do work with people who fit them very well, so I don't run that clinic.
I'd like to work for a first correction.
But it's amazing how it's amazing. You know what? I love it.
No, I think orthocare is great. I just would be surprised if anyone chose it almost.
Yeah. Okay, so we're going with the single vision lenses and then review in 12 months. Oh yes, and then we're down here and lifestyle changes. It's all
I have
happening.
a question.
Go
Why
first.
would you not do orthocare on your child as a first-time measure if their
Ask the audience. Ask the
if
audience.
their lifestyle is such that they need to be glasses free during the
Does
day?
it work okay, like if you're a 50 though?
Yeah.
Half a dial to my own.
There's got to be a challenge.
Sorry, this panel is not excluding orthocare. This is the voting of the audience. Okay.
I don't have a voter at the minute. I might just say,
I think that was just a pragmatic, if it's very
Our child who needs to be spectacle free during
Yeah,
the day.
fair enough, -125. But I was thinking like someone coming in at -50.
yeah, because they're first.
Depends what you mean. It depends where they are at first correction.
I think that if you have low prescription, you don't have enough, let's say, power.
Yeah, and then
Yeah, I don't have much experience in ortho-K. Unfortunately, I work with two colleagues. who work with
Pascal,
that.
not everyone works with lenses that increase the addition ring irrespective of the central optic zone
This
treatment.
is all.
So,
But you can.
okay.
But they do.
Probably our answer will be different also if instead of reviewing in 12 months, if we'll say reviewing in
6
6 or
months.
3 months.
Mhm.
I have a question. How many children, this percentage of 6-year-olds, where the family goes for ortho-K as primary treatment
In Europe or
in Europe?
not many.
No?
I wouldn't know how to access that information really.
Depends by country as well,
Yeah.
because it depends on the training and the optometry of the
There's
individual.
also regulations.
And 6 to 8 years ago, the response will be completely different.
Yes.
Now we have more options.
They do.
That's-
They've become very popular. I mean, I can't get over it. It's the fact that the children have nothing to do during the day. This is what they love. And the swimmers, anyone involved in aquatic sports. So they're more popular than I could have anticipated, but they really are. With those who wear them, I love them. But again, it's they're out of my chair then and into my concern.
And there are many other considerations. If the question will be in a child that don't like spectacles, do I prefer do not wear the spectacles and be undercorrected or prescribe something that will happen every day? Okay. So
Yeah,
in
it's true.
that case, Pascal, you did it. We saw you. So there is a lot of individual considerations in that way.
There you go. And then the lifestyle changes. Well, there we go. That's important all the time for everybody. So let's
Both is anonymous, by the way.
so there we go. So that's the end of the voting. I've closed it off.
Yeah,
And then
next one.
okay, crept in there at the last hurdle. Okay, so how to treat lifestyle and visual hygiene counselling. So this is what we've covered already, and we discussed this with all children at the visit. And actually, I find that in practice too, if I give the children ownership of that and say, well, it's how do you see as a family you can fit this into your day or fit it into your week, and give them the responsibility to make sure that it's not just them, but it's their family and their parents and everybody else. Because you don't want your child to be able, you have to be outside in the garden and the rest are inside on their screens. Avoid encouraging children to hold themselves as far away from them as possible at arm's length. 30 centimeters is going to be tricky for small little people with short arms, but in other words, avoiding holding, their tablet or their screen or their book at, very close to their face, about 10, 15 centimeters is not a good idea. And then to take breaks, just to take breaks. Outdoor time, again, and reinforcing the importance of spending time outdoors and getting involved in physical education. I think also remembering that kids are great with contact lenses as well, and that helps support them remain engaged in sporting activities, because if they see well, they're going to play better and they're more likely to stay engaged in sports. So I would be somebody who would advocate highly for getting children to contact lenses as early as possible. The other thing about contact lenses to bear in mind is that treatment effect stays consistent in different positions of gaze, and we can't be sure of that with the spectacle lenses. Okay, so we know that outdoor light exposure reduces the incidence, may reduce the progression. The jury's out on that. I suppose the research has been equivocal on that. However, it may be that short-sighted children or myopic children require more time. They just need a higher dose of daylight. So we're looking at lifestyle, different types of spectacle lenses. We're getting great results with the new spectacle lenses, whether they're the DIMS or the Stellest lenses. Both are working really, really well. Contact lenses, we use a lot of contact lenses in clinic as well. The drops I put here because they're available in some places, but we don't have access to them in Ireland. Is that the situation in Europe throughout? That people don't use that
I think so.
So see in previous slide, I was just wondering, you're talking about 120 minutes of intermittent
Yes.
outdoor light. I was wondering what the rationale is behind that. Is there evidence to suggest that 2 hours constantly has a differential effect as opposed to it being split over the time course of the day? Because I'm assuming you'll different wavelength characteristics of the light, whether it's dawn, dusk. So I was wondering why intermittent and what we.
I think it's going to be tricky to get 2 hours in one go.
Just really coming back to colour
Yeah.
perspective.
And also, well, I don't know, I haven't read up any research to suggest that it needs to be on a one go. I haven't looked at that, but I do know that ideally, if you think about it, it'd be great if you could break it up to, so that if you're getting daylight in the morning, it's going to be very different to daylight in the middle of the day, to daylight in the evening, because you think of, you're again looking back at your spectrum, a lot more blue in the daylight in the morning, alertness levels are increased, and then in the evening, you're getting the warmer tones, and that will help with sleep and everything as well. So I think it's a very good question. But I don't know that there's evidence comparing A with B, okay? But it's more likely to be successful if you break it up. And at the weekend, there are possibilities that children involved in sports can get like 2 hours in one go. But in Ireland, in the winter, that's not going to happen. Like, we're 53 degrees north where I am, and it's pretty similar here, isn't it? The daylight is limited in the winter time, and we need to encourage children to get outdoors. So I do engage with schools on that as well. I do engage with schools because a lot of that has to happen during the day when they're in school. Unless the schools are on board, that's not going to happen. By the time parents are finished in work, collect children, many children aren't outdoors at all. And many of the parents bringing children into me now are based in apartments, and there's no garden or a park nearby. Like, it's the way people live their lives is changing, and it is impacting kids' vision, I think. So, 30-30 rule, if we can work to that, hold screens greater than 30 centimetres for 30 minutes, and then take a break outside. And that's just really summarising the different types of treatment there. There are new novel areas of interest as well, like the red light and blue light therapy, and the violet light and different types of frequency. I'm a bit concerned, really. I'm not sure. I think Lisa Ostrom had a very nice paper there recently looking at the safety levels of the lights that were used for red light therapy. I wouldn't be rushing to it myself, but
Is this in the Navigator? Sorry,
oh no, that's not in the Navigator. That's the slide. Yeah. But there's something you could, most of this will be, you'll find in the Navigator. I just have a few slides there, but you can look into the different treatment modalities in that as well. Efficacy, so looking at the single vision untreated, that's what most children are given when they're short-sighted. And we know that's not effective, but it's better than not giving anything at all. Just need to highlight that. It is better than nothing, but it is treated as your control group in the myopia clinical trials. The PALS, the multifocal glasses, and the 0.01% atropine are about the same level. I think we already think about that how success is determined when it comes to drops is different than it is when it comes to contact lenses and spectacle lenses, because it's a drop as opposed to a technology as such. So it's just interesting to see that you're getting, the words, no voice. And then also the bifocal lenses and that. I mean, we're really aiming for treatments that reduce myopia progression by about 50%. Okay, and that we know the results are good on this with regard to the spectacle lenses, Ortho-K, and the slightly higher doses of atropine. Again, I'm not using those. And in Ireland, some children do receive them from ophthalmology, but that is off-label. Okay.
So to say that these efficacy levels might be in axial length terms, because in refractive terms, even the 0.01 atropine might show us a very expressive efficacy, but in axial length terms, it's like that.
It's like that. And also,
and in Europe, for my knowledge, many people is doing in ophthalmology 0.01 to all the kids.
And really, if you look at that, it's about the same level of efficacy as you will have with the PALS, progressive additive lenses that we've dissed for a while. I mean,
in axial length terms.
Yeah, so maybe, I don't know, it's an open question, but it's interesting.
Do we have enough evidence yet in Western populations to truly comment on the efficacy of 0.01%? To my understanding, the Australian study had quite a number of dropouts because of COVID. I know there's a very recent one, but I'm wondering, is it too quick to rule out 0.01% as a treatment option?
Well, I know the Mosaic trial in Dublin published last year, and 0.01% against placebo for 2 years, and the results were modest efficacy, particularly more efficacious in the white children with blue eyes, because they had some non-white children in the study and found really no efficacy from 0.01%. But they also found an effect. They felt there was an effect of COVID on the efficacy of the atropine, as well as sort of behaviour or environments, interactions with the atropine. So I think the jury is still a little bit out, but I wouldn't be rushing to use 0.01% low dose atropine. Be like the results aren't showing. The CHAMP US study as well, and then there's a CHAMP UK study that should be published sometime soon as well. So yeah, there's more data coming out. But
And the results on the 0.02% were better. Yeah, marginally better.
in the US study,
Yeah.
they were worse than the 0.01%.
Oh, were they?
Yeah. So again, COVID came at a very bad time for those studies. They all started around the same time and they were all impacted by COVID. So I think there are always going to be question marks over the efficacy reported from them.
And the impact of behaviour during COVID,
Yeah.
which was different. Because in some places people were housebound, but in other places they were outdoors all the time and not in school. So I think sometimes that it's hard, it's muddies the waters.
It's going to slow down our understanding, I think.
It is.
Yeah, there are some Danish studies ongoing on low concentration morphine. You can really see some publications within a couple of years on mostly blue-eyed children, of course.
That would be really helpful, I think.
And I know that in Sweden, where I work, the ophthalmologists, those who atropine, they start with 0.01. And if they don't see any decent effect, they
In axial lens.
well, that depends on if the doctor has
Because if they look at the refraction, they are going to find the efficacy.
But it will take some time.
That is not the point.
For everybody is having actually.
I will just mention one recent meta-analysis from 1.5 years that show a span of at least 8 different concentrations. Of course, not all the studies there have the same strength in terms of unbiased results, but they show quite nicely the balance between the efficacy and the side effects. And it seems that 0.05 and might be a little bit different in the future. It seems to be a sweet point between not having side effects in terms of pupil dilation or much significant accommodation deprivation and efficacy in terms of axial length. So it's not the definitive answer, but seems that this is a little bit up from the 0.01 that suddenly all the ophthalmologists prescribe this in Europe, at least in Southern Europe, based on axial length. But hopefully they are not any more trusting on 1%. That eliminates the tonic accommodation, and then when it comes back, we saw tremendous effect and tremendous rebound. None of those is true. It's an advance.
There's a typo there in that slide. Don't mind the 0.025. We'll move on. That's not a new way of presenting percentages of atropine at all. But I think maybe coming back to the 0.01, there may be a place for that as an adjunct therapy. You know, that it could be combined. That's in time to come. We will see. We will see. So basically, which one is best for the child? And that will depend, I think, on the visual task analysis, because the treatment that will work best is the one that suits them best and ties in with the way they live their life, the way the sports they're involved with, their activities, the one they like themselves. So it's the intervention that matches their lifestyle. I think that's really the one that's going to work best. And this will change and evolve over time. So how do we determine if the treatment is working? And this is the next poll.
Is now working?
Is that working? It is working, is it?
Not sure. Yes, it is working.
Nobody knows the answer though, because no one's
Now we can go.
Just read.
Yeah. Oh, do I move on another one? Do I move on again? Choose. Or hang on.
You can move.
I move now. Oh, look, it's all happening. It's very dynamic, isn't it? Interesting, isn't it? Well, anyway, no one's interested in the improvement in vision relation quality of life, that's for certain. But there's no right or wrong answer really here. I mean, it was just.
I think 12 months makes sense to me because you've got the full season, you've got the whole year. But I would want to look at them after 6 months and see how they were managing, see what their vision related quality of life was like and what they were, how they were complying with the intervention, get some feedback. But I might not want to make a big decision about whether it was working or not. And it depends what we mean by effective too. I think we still don't have really brilliant tools to help us identify whether something is effective or not.
Maybe we will expect that in this initial of treatment, when the effect is the maximum in many of the optical devices, we will expect a growth similar to the non-myopic eye.
Physiological.
So, or even a non-growth, but I will say even some growth will be a good notice if it is at the level of the emmetropic eye. Maybe
So
0.10 a year, 0.5 in 6 months.
It depends on their age, surely.
Yeah, with the slide not
Oh, okay. That's question.
slide to cross something.
I just always worry about that 6 months, because if it's 6 months during the summer versus 6 months during the winter, I think, and study data as well, we have to take that into account. But seasonal variability.
And also we found that with a lot of the studies, I suppose the effect was strongest in the first 6 months. That a lot of them showed that 6 months is wonderful, treatment effect that didn't continue on. So that should kind of give you a pause. You can't extrapolate out that it's going to keep going at that rate. So yeah, I agree. So see them regularly. But sorry.
Sorry, I know that time is crucial, but shouldn't we wait or be patient more about 2 or 3 years of a treatment, because the growing of the child is not periodic activity. So sometimes they grow much in months, and other months are just quiet. So our goal shouldn't be that the growing curvature, the maximum amplitude should be the less what is possible, because the rapid growing is more tissue damaging than just a slow period of growing, right? So that's why 12 months shouldn't be enough. I mean, most of the treatment options are not that average equal in 12-month period. So 2 or 3 a year for a period of treatment should be more answer to us, and we should do an average of that years. So in 3 years I could get more valuable information.
Yes, it has.
But I will say that is valid for the studies, but for the individual patient, it's probably not good, because you will have to act. If you wait for 3 years, you have wasted 3 years that never come back. So in the individual patient, in the clinic, I will say we have to make quicker decisions and have some indication if the treatment is working or not. So the 3 or 2 years we speak in terms of clinical trials, that not apply to the individual. Is my opinion.
After the year, you continue the treatments. The goal is not to and you can make a combination. You don't need to change the first treatment if the patient is happy with the treatment. So you don't need to go to the test or okay just because the treatment stopped. So you can combine with that treatment and see after 1 year or 6 months what happens. And then if it slows down, you take away the drugs.
And then we try and figure out if you're not getting the results you'd hope for, or you'd expect it. Maybe drill into why not. They mightn't be using
compliance.
Be using them, and then if they're not, I mean, a child at 6 or 7 might, do gymnastics for an hour of the weekend on a Saturday, and then suddenly at 10 or 11 they're joining the club and they're doing it for 6 or 7 or 8 hours. So you might need to move them to contact lenses at that stage, so that they can still have a treatment effect, but they have a different visual requirement too. So they're different things. But with regard to efficacy, I know where you're coming from. On the trials, we need 3-year data, because we need to know the average over 3 years as opposed to a year or 2. But when it comes, and so as you're saying, when it comes to the individual child, it's hard to communicate that success or failure to a parent. Say we have to wait for 3 years. It's just too long, even from a communication point of view. How to set up. I think that the profile curves like they have in Primo and other technologies are useful to help communicate, because the communication piece is huge. I think it's probably the most challenging.
Yes.
I really think it's the hardest part of this. Communicating with the child and the parent simultaneously is a challenge in terms that are out there that everyone is comfortable with. So when they come back, and this is what we're going to do, we're going to see, does the treatment still suit them? Does it suit is the treatment suitable for their vision and eye health needs? Does it still suit their lifestyle? And is it working? And is the treatment working to slow down the progression for the patient? So I suppose this comes back to the early part of the appointment when you're looking at compliance. And that is key because we know a lot of the studies, the studies of the Stilest anyway, particularly, had looked at compliance and figured out that if children wore the lenses, the spectacle lenses for 12 hours per day, there's some level of success, and the more they wore the glasses, obviously the more successful they were. So this interesting that data has been collected. And also we know with the contact lenses as well that compliance seems to be the key here. And how do you maximize that? You know, it's challenging to come up with ways of encouraging children to wear their contact lenses when they don't want to wear them anymore, or if it doesn't suit them, or if they don't want to wear glasses. How do you encourage them to do that? So I think they work if they wear them, if they're happy and if it ties in with their lifestyle. I think lifestyle is huge. There's some non-modifiable risk factors for faster progression. The younger they were when they started to become short-sighted, obviously they're going to be on a different trajectory than if they started when they were 12. It's going to be different than if they started when they were 6. And then also, if their parents are short-sighted, if they're myopic, it's going to be more of an issue. And, so there's some things we can't control. But I think, and again, this is just dealing about when do you make a decision on that. And I think it's probably good to see them 6 monthly and then have that open discussion. And I find that with the children themselves, like, how do they like to spend their time when they're not at school? Like, what do they love to do? What do they want to rush through? How do they spend their time when they're at school? Learning about how they spend their day and what they find challenging and what they find rewarding, and seeing how you can support that. So I think the communication is huge there. It's huge at that early stage when you're, sorry now, I found the screen here. You see me looking sideways. I'm not sure my lenses are enabling me to see the tiny screen over here. But the evidence is there that if you adhere to the recommended wearing times, you get better results. And this is a lovely study, and this was all to do with the Stilest lenses, and it showed that children wore their lenses for longer periods of time, and the success rates were better. And also then we have to look at, spherical equivalent to fractional. This is what Catherine and Jose were talking about earlier. And, how do we figure out what is normal progression and how much a child's eyes will change over time if they are, if they are in single vision lenses or if they're myopia management, what do we determine to be success? So therefore, at 12 to 16 years of age, at that stage, we would like to see that we were keeping it under 0.25, less than a quarter of a diopter. At a younger age, at 9 to 12 years, if we could keep the progression to less than 0.37, that looks like success. And if they're younger than 9 years of age, if we could keep the progression to, half a diopter or less, that we would consider to be success. And then with regard to axial length, we know that the emmetropic child's eyes are going to grow anyway. We're talking about physiological eye growth. So therefore, if, we can keep their eye growth to, 0.1 millimeter in their teenage years, we're comfortable with that. We're not going to stop their eyes from growing. I mean, they're growing, they're children, their eyes are growing, but we just don't want them to race off at 0.2 millimeters or more. And then again, with the younger kiddos, 0.3 millimeters or more. And so this is when we're thinking about physiological eye growth. Okay, so the next thing is then to explain our results. Explaining the results, explain myopia, establish what they like, they don't like, explain what progression looks like, and displaying progression is very important too. We have tools now like Primo, and there's other tools such as Ocumetra and are there others? I don't know, but they're very useful because it's very useful to have something we can show parents so they can link in with that afterwards. And also parents actually can link in with the myopia management navigator as well, because they have so many questions in your room, but the questions often come afterwards. And it's nice when you have platforms set up that can help you communicate what myopia is and what we expect can happen and how we can try and limit the progression of it. So it's useful, and it's useful. You can provide the link, it's free to the myopia management navigator, and parents can link in with that, and then encourage questions. Okay, so we're going to go to the last question. Everyone, you'll be delighted because we've only a few minutes left. When do we stop treatment?
Good question.
When do we stop? What do you think? What do you think?
You're asking me?
Yeah, what do you think?
I would keep going while the child is in full-time education.
Yeah.
If it's a an intervention that they're comfortable with, that they can afford, that they're seeing well with, then I kind of feel like you can continue to progress through your later teenage years, through your early 20s. But I'm thinking every child is an individual, so I think that you're kind of balancing those. I wouldn't necessarily take any of those metrics, like less than a quarter of a doctor over 12 months or whatever.
Yeah.
If the child was happy and they could afford to carry on with it and they were complying with it, you can kind of keep them in it. But we don't have trials that last 10 years to really tell us that. So I suppose I'm being pragmatic and looking at the evidence and thinking, and putting it onto an individual child with their individual risk factors and making decisions that way. I think we often look too quickly to metrics and kind of go, if the number is that, then I need to do this. Whereas we're all clinicians and we should be able to look at the evidence and balance it and apply it to an individual child. So whilst all these support information, like Primo, like Ocumetra, like the growth curves and the biometers, they're all really useful. But at the end of the day, we're the clinicians and we have to make a clinical judgment about that child in the chair, not about the average myope, because that doesn't really exist.
Is there some criteria in your clinic to stop, or again, it depends case to case?
We have criteria. I mostly work with kids under 8. So our criteria is have a diet of 30 a year, 0.1 million a year.
Now you put them in single vision lenses after that?
Well, I use atropine. So if that doesn't help good enough, I will increase the concentration. If that's not good enough, I will refer to an optometrist.
But now we are at the point where the things are close to stabilize. So when to stop? When to stop the treatment?
When they have progression of less than half a diopter here.
Less than half a diopter for you.
You're taking them off, Yes, I suppose I'm thinking about this from a spectacle contact lens intervention clinician because I don't have access to that. So I have to correct the optics anyway. So whether I do that with a single vision lens or a myopia control intervention option, that's where my thinking was coming from. So that's really interesting, the idea that if you're taking a pharmacological approach, you're looking at a slightly different consideration. And do you take them?
Yeah, I was thinking that's taking
No.
So they just come straight off first.
You use 0.01.
0.01.
That's what you
You couldn't really take them much.
You okay once a week. Yeah.
It's already happening.
Oh, yes, you're
Have you
already.
seen the outcomes from the recent Atom 1 and Atom 2 follow-up studies? So they looked at 10 years on from Atom 1 and Atom 2 and found no benefit from actually any of the different concentrations in a sample of those.
Yeah, we were kind of relying on the Danish colleagues and some clinical experience from one city in Sweden. Although there was no Swedish studies on this. The Danish has done this longer than us, and they swear by effective low dose atropine in your children. So we'll go into that until something else shows up.
You wouldn't feel any benefit of keeping them on until they've finished through those kind of risk factor years where they're doing more studying and, if it's cheap, if it's tolerated, if it's safe. I'm just throwing out there.
Atropine eye drops are free for children in Sweden. So many parents, they go for atropine because it's free. Glasses and contact lenses, they are costly. They get very little reimbursement for that. It's 50 or 80 euro per year, depending on the age of the child.
The thing here places again on the ethical side. So should the government pay for an update on that treatment, probably the 0.25 or the 0.05, and continue paying? I'm sensitive to the thing of if it is free, it will arrive to more people and more people will benefit. But investing in something that is free, when probably there is another alternative that is more effective, is start to be doubtless. But I'm not saying that it's not working in Denmark. I'm not saying that. I don't know that.
But is it free because the health insurance pays exactly like what they know? Because in Switzerland, it's for free because the health insurance, they get a prescription, they get from the pharmacy, they're invoiced, and they pay because they have no idea what they pay. So it's not because it is accepted from the health insurance, HLC prescription.
No, it's
because it's a prescription, they have no
Yes,
idea.
it's not all drugs are for free, which are it's prescription drugs. They are for free until you are not. Oh, so the parents are, of course, the government is.
Yeah, but
This
it's
is
not
the last
because
question?
It's the last
the health
question.
system will accept it as a treatment. It's because
No, it's not accepted as a treatment. No, it's just a drug. It's
So it's
just
off-label
that's
then, really.
not they pay, so without knowing what they pay.
Bruce had a question.
Right.
Has that, or
I
is
just-
just some kind of
Yes, yeah. I just going back to the question of when to stop. I know in the DREAM study, which was a European population, they found that myopia stabilizes by the age of 15 unless it was 5 diopters or more.
Oh, that's
Yeah.
interesting.
So I wonder, and then it stabilized when they're older. So I wonder if we should take that into account in our decision of when to stop treating.
It's interesting, isn't
Because
it?
the high myopes we should be scared of.
But I think that should not be 100% certainty on that, because we still see 15 and older with lower myopia still progressing.
And was the DREAM study, were they doing retrospective data?
But it's a good
analysis? Is that from, yeah, so, you know, the factors for those people who were born, I don't know, the last century, yeah, and makes them sound like ancient people. But no, I do think like modern lifestyles probably are having a slightly different impact.
Yeah.
And on average, -5 at 15, but not everyone's average.
It was published in 2021, so
But I think it's
data year
retrospective.
pre-COVID.
25 years of
Yeah, so they were looking back, so even when they published it, those people were out.
early days.
I would like to see that.
Thank
It's
you.
an interesting one.
And again, it's a bit like the Comet study, where they found, and this is older as well, because this is like BC, you know, last century. And basically you had, at 15 years, about 50% of them were still progressing. At 18 years, a quarter of them were still progressing. And at 21 years, 10% were progressing. Now, this is pre-treatments or myopia management technologies. So in other words, we can expect that to happen. And as Catherine says, with the lifestyles that children are living today and the visual environments they're exposed to, and it's a new world, isn't it? We need a new study.
Slide.
We need a new slide. We need a new slide. Okay, so in other words, we know from in college, because we've been doing the school study and looking at the children, they're not children, I have to. They're not children, they're young adults, my students. And they have we were looking at the refraction and biometry every year, and they are progressing in college. The myopes are progressing and they're adults. They're young adults, but they're adults and they are progressing.
Mhm.
So in other words, we know that some do. Okay, so communication, the outcomes. This I think is probably the most challenging part in communication with parents. That we can't stop myopia progression. We can maybe slow it, and that it's important to do that. That compliance is important. I'm always afraid to mention the term compliance to children, because I think once it comes up, then they don't want to use it. But and usually I found that children, if things work and suit them well, and you've really engaged properly with the visual task analysis, they tend to work really, really well. Also, when it comes to I don't know how you found this, but I found that our dispensing optometrists, our dispensing opticians have become so important since we've got into the myopia management spectacles, because they need to fit perfectly. They need to fit absolutely perfectly. And that we have found in the college, we're getting these wonderful results, but then out in the wild, sometimes things aren't working so well, and they arrive back into, we see them later on, and they're just not fitting. It's a bit like when we were fitting glasses for children who were ambuloptic. The fit is very important. And managing expectations, and then keeping on top of the science and the data. So that's really just repetition. And that's just reintroducing again the myopia management navigator and what it's about. I would recommend and ask people just to have a look at it, and all feedback is really, really welcome, because it's an iterative tool and can be updated. You can look at it at a high level, or you can dig into the different sections. You can get lost in them as well. But I think it's useful, and it's useful when you're in a busy practice because it's very hard to keep on top. Keep on top of the science. When I wake up in the morning, my alerts every morning when I wake up, I have so many alerts. You ought to. And how can you run into your clinic and see 30 patients and keep on top of all of that? So it's nice when you have different people synthesizing that information for you and helping you to communicate that to parents and to children themselves directly. My fear with the communication piece, though, is really big at the minute because I have noticed that in Ireland, where I'm based, and it may be happening elsewhere too, that a lot of people have embraced that, yes, we need to, slow down myopia and that it can be pathological, but that maybe you can be frightening children. And we need to think in terms of how we present that information to children so that we can be as positive. It's a bit like when you're going to the dentist. How do you look after your teeth so that you can ensure you hold on to your teeth for the duration of your life? But again, with vision, I've had parents come into me that have been elsewhere, and the first thing a child says, "Am I going to turn blind? Is my retina going to come off?" And it's happened a few times. So I just think we need to, thinking back to Ariana's talk earlier and Malcolm Butler's talk earlier on communication, they were wonderful. Really, I'd recommend you have a look at them if you weren't there, because the communication is key. What do you think? Anything now? Anybody would like to close off? Any questions? Any comments?
I have a question.
Do it.
Do you find any connection, any scientific data about relationship between pupillometry and myopic progression?
There is some data on that. I'm not abreast of it, but I should look more into it. Catherine might be able to. Are you?
Well, we looked at pupil diameter in children in the UK wearing the MyoSmart lens, and the children with the larger pupils at baseline, these were children aged 5 to 15 years of age, had more efficacy wearing the lenses than children with smaller pupils. And we're following up on those kids, so we'll see whether that progresses beyond the first 12 months. So I don't really know what that means, other than maybe
there has been some in
larger
orthokeratology as well.
Yeah, so with the ortho K side, with the larger people, you get more efficacy. So presumably that means that they're getting more of the peripheral plus in the periphery because they've got a bigger pupil. But
more retinal area being affected by the defocus treatment
Yes,
you want
but
to
the original defocus shouldn't be wider as well because the blending happens by the iris. So it's a
bending of
the closing.
Bending of what?
Restriction of the light.
It's the upper two. Yeah. So the iris just blocks the incoming light.
I would say it is a complex relationship between at the same point a smaller pupil will increase the depth of focus, will improve image quality, will improve contrast. So it is certainly a tricky connection, but there starts to be some consistency between the larger pupil diameter and the more efficacy in those devices imposing the focus. It's the hypothesis. It's not a definitive answer, but the hypothesis is the wider the pupil, the more peripheral retina to be exposed to the focus stimuli. But there are many other confounders in that relationship, as you said.
Like the environment. I mean, if they are outside, the instant intensity of light is more. So smaller.
Larger pupil, more lighting.
maybe it doesn't contract as much.
But more pupil?
That side.
Yeah.
Smaller pupil. More light, smaller pupil.
Nobody's looked at it in like in a dynamic way, so measuring pupil size in children in a systematic way across different light intensities, different environments, and the different treatments. But I think it would be a beautiful thing to do. Be a really challenging study to undertake, but I think it would be really interesting. And I think what we're going to be seeing more and more is a more stratified approach to identify which child will benefit from which treatment at what age and for how long. And we're just really at the start of that at the moment. And I think pupil size, pupil iris color, ethnicity, all of those things are likely to be in 10 years' time when we look back, we'll be thinking, oh, we were just giving them all the same treatment or very similar treatments, and we weren't being stratified in our approach. Like a lot of medicines, much more personalized and more stratified. So things like pupil size absolutely would be a great point to bring up.
The thing is, which pupil size? It should be an integrated measure of what is the pupil size of a patient throughout the day, because we measure it in clinic under very specific circumstances. Even if we measure under different levels of lighting, what is the fundamental certainty we have that this is representative of the pupil size over the day. Is like what is the distance you want to read, and the patient sees it, but over the day the distances are very different. So it should be a comprehensive and integrated way to measure the pupil size over the course. Probably a device that is in your eye measuring an eye tracker through the day the pupil size of that kid. Because the measurements we have are very discrete, are very specific and very specific conditions.
With so many things, that we are really restricted by the tools that we have to track children, to monitor, so a lot of the data we get is from self-report, wearing time, all of that. It is noisy data, it's messy data. If we could put them all in cages, and this has been zoomed across Europe, and keep them in really controlled conditions, it might be easier to determine the answers, but we can't do that.
Okay, so we need to finish the session.
Very good.
Thank you very much, everyone. It has been an interesting discussion. Stay tuned. We will continue this discussion on Academy Hour over the year, and for sure next year in Ljubljana, we will continue discussing this. Thank you very much for all your input. Thank you for people in Zoom as well.